Good morning. This is Tom Roland. Welcome to the paper session related to cochlear implants and their implementation. Dr. Ma and I will be co-moderators and would like to thank the committee that reviewed the submissions for selecting an excellent group of abstracts for presentation. 2 talks are worthy of awards will also be presented. So with no further ado, why don't we begin the session?
Hi, I'm Jacquelyn DeVries. I'm an MS4 at the University of California, San Diego, and I'll be presenting our study, Exploring Factors Responsible for Delay in Pediatric Cochlear Implantation. I'd like to thank my co-authors for all of their help and guidance with this project, and we would all like to thank the ANS and COSM for giving us the opportunity to share this project. We have no disclosures. Previous research has demonstrated that children receiving cochlear implants before age 2 have improved language outcomes. These children can enter 1st grade with expressive and receptive spoken language skills similar to their hearing classmates, but certain populations have been shown to be implanted later or less often. Like disparities that exist throughout medicine, these include differences based on race, socioeconomic status, insurance type, and language barriers. Publicly insured children are now implanted more often than they were in previous years, but timing may still differ based on insurance type. So this study sought to better characterize delays in implantation in our patient population. This was a retrospective chart review based out of our tertiary referral center, Rady Children's Hospital, San Diego. Our study population was pediatric CI recipients at Rady between October 2015 and February 2020. Data that we collected included demographic information regarding age, sex, ethnicity or race, language spoken at home, insurance type, distance from the CI center, and median income of city of residence. For hearing loss history, we included the etiology of hearing loss, if known, family history, cochlear abnormalities, and age at diagnosis, amplification, CI candidacy identification, and surgery. Wait time from each step of the evaluation process to surgery was measured as well as the children's implant profile or CHIP scores. Surgical details included unilateral or bilateral implantation and simultaneous or bilateral sequential implantation for those bilaterally implanted patients. We evaluated our entire patient cohort of 72 patients, as well as a subgroup analysis of 26 patients with bilateral profound congenital hearing loss. So this is a schematic of the cochlear implant process at our institution, consisting of candidacy identification, followed by imaging, developmental, vestibular, speech, and CHIP score assignment in no particular order prior to surgery. So 72 patients were identified who had undergone primary cochlear implantation at our institution. Our patients were primarily Latinx or white. English and or Spanish were the most commonly spoken languages at home, and 61% of our patients were on a public insurance plan. Children of Hispanic ethnicity were more likely to have public insurance, whereas Caucasian children in our population were more likely to be privately insured. In our patient cohort, children with public insurance were older at hearing loss diagnosis, cochlear implant candidacy identification, and surgery. This difference was largest at the time of surgery, with privately insured patients implanted at 3.1 years old, whereas publicly insured patients were 6 years old on average at the time of surgery. They also had longer time elapsed between identification as a cochlear implant candidate to vestibular, speech, developmental assessments, the CHIP discussion, and surgery itself. Overall, the CHIP scores were not different between groups, but concerns regarding educational environment and support were higher in Spanish-speaking children and those children on public insurance. Age of implantation was also older in patients from the lowest income areas, but this was not significant on multiple regression analysis. On multiple regression analysis, public insurance was associated with a longer time from candidacy identification to surgery and older age at time of cochlear implantation. To eliminate any potential confounding by progressive hearing loss, delays in diagnosis, or children who were delayed because they had initially been worked up at other centers before beginning the process at Rady, the subgroup analysis was done with 26 patients identified with bilateral profound congenital hearing loss. Even in this more homogeneous group of patients, publicly insured patients continued to experience delays. Age of implantation was significantly affected by insurance type based on multiple regression analysis in this subgroup as well, with privately insured patients being implanted at 1 year of age, whereas publicly insured children were 2 years. So although overall access to cochlear implantation has improved in publicly insured children over recent years, disparities in access to cochlear implantation continue to affect the timing of surgery. Since age at implantation is known to impact successful spoken language and communication skills, this disparity should be addressed. Publicly insured patients experience delays with regards to each evaluation in the pre-CI workup, which likely contributed to the difference in age at surgery, time from hearing loss diagnosis to surgery, and time from CI candidacy identification to surgery. Despite cochlear implantation being covered by public insurance in the United States, the timing of surgery is not yet equivalent across insurance types. Insurance approval problems may be playing a role given that prior authorizations are required before each step in the pre-implant process for publicly insured children. And given that 59% of children nationwide are on public insurance, better understanding of these continued disparities represents a prime opportunity to improve access to care in a meaningful way. We'd like to thank ANS and COSM for the opportunity to present, and thank you for your time.
Good morning, everyone. My name is Anthony Tai, and I'm a fourth-year Stanford medical student. I'll be applying into ENT residency this year. I would like to thank all my co-authors for their work on this project and also the ANS for giving me the opportunity to present. Today, I want to talk to you all about outcomes in patients who meet cochlear implant criteria in noise but not in quiet. I have no conflicts of interest. Currently, the most common insurer of the elderly in the United States in terms of public insurance is Medicare. One of their criteria for cochlear implant candidacy is an AZ bio or sentence recognition score less than 40% correct. However, they do not specify whether this should be done in quiet or in noise, which would be more representative of daily life. Several studies have assessed whether patients who qualify in noise but not in quiet derive benefit from their cochlear implants. However, most of these studies do not factor in the test-retest variability in the AZ bio score. Furthermore, it is unclear if the 40% Medicare threshold is really the optimum threshold for candidacy. Based on these gaps, we wanted to address several points in this study. Firstly, do patients who qualify in noise but not in quiet derive benefit from their cochlear implant? And if so, does this benefit go beyond the test-retest variability in AZ bio? Secondly, what factors are associated with improvement? And lastly, what is the optimum candidacy threshold for cochlear implants? In this study, we split our population into two groups. Those who qualified in quiet were qualified based on the Medicare threshold of scoring less than 40% in AZ bio quiet. The noise group did not meet such criteria in quiet, but did do so in +10 speech to noise ratio. As I mentioned, there is some test-retest variability in the AZ bio. Previous studies have determined that the 95% confidence interval for this variation is 15 percentage points. So we set that as a threshold for within subject improvement of each patient. This chart here represents the demographics for our patients, where we had about 200 patients who qualified in quiet and about 24 who qualified in +10 speech to noise ratio. As you can see, multiple demographic factors and device characteristics are similar between the two groups. This chart here depicts the change from pre-implant to post-implant scores at least 6 months post-implant for patients who qualified in quiet in gray and those who qualified in noise in black. Both groups improved to a statistically significant level on both tests, but as you can see, the magnitude of improvement is much larger for patients who qualified in quiet. And so the question is, what percentage of patients in each of these groups actually improve beyond the 15-point threshold I mentioned that represents the test-retest variability for AZ bio, quiet and in noise? So this is what this chart here depicts. If we focus on the far left on the AZ bio quiet score and look at the gray bar, that represents that almost everyone in the quiet group improved beyond 15 percentage points in AZ bio quiet, whereas less than half of patients met the same criteria in the noise group. And you can see the same trend across multiple preoperative scores, where no matter what the score, patients who qualify in noise are significantly less likely to improve more than 15 points compared to those who qualify in quiet. So the question is, why do some patients benefit and others not? What are the factors associated with improvement? In order to assess this question, we performed what's called a model comparison analysis. What this means is we started with a reference logistic regression model, where the outcome is improvement beyond 15 points, and the inputs are the demographic factors listed at the bottom of the table, as well as the baseline AZ bio quiet score. We then compared the area under the curve of this model compared to other models that included one or more than one other preoperative scores. What you can see from the table is that the baseline AZ-Bio score is the best predictor of improvement beyond 15 points, and that adding multiple different tests, as seen in the models at the bottom of the table, does not improve the predictability. Therefore, we focused on AZ-Bio quiet and wanted to see what is the optimum AZ-Bio quiet threshold that predicts improvement beyond 15 points. To do this, we plotted the sensitivity and specificity of the AZ-Bio for improvement across multiple AZ-Bio scores. As you know, the current CMS criteria or Medicare criteria is an AZ-Bio quiet score of less than 40%. When we tried to optimize sensitivity and specificity equally, we found that the statistical optimum is actually an AZ-Bio of 30%, and that patients who score less than 30% preoperatively have about an 80% sensitivity and 70% specificity for improving more than 15 points. However, I should mention that this is a statistical optimum, and any clinical optimum will have to take into account several factors. Firstly, we might want to consider whether sensitivity or specificity should be weighed more heavily. If we want to extend cochlear implants and have as many patients improve as possible, we would weigh sensitivity more highly. Whereas if we wanted to reduce surgery and other costs and risks for patients who are unlikely to improve, we would weigh specificity more highly. Secondly, the metric for improvement here was that 15-point threshold of test-retest variability in AZ-Bio. However, it can be argued that quality of life surveys will be more representative of a patient's subjective sense of improvement. And unfortunately, those scores were not available in this study. Our study was also limited as it was a single center retrospective analysis. And at some points, we did have fewer patients who had postoperative scores in noise. In conclusion, patients who qualify in noise as a group are likely to improve from cochlear implants. However, they are less likely to benefit compared to patients who qualify in quiet. A low preoperative AZ-Bio score was one of the best predictors of improvement beyond 15 percentage points. And really, we do need a lot of further studies to determine the optimum threshold for improvement in quiet and in noise. And these would be very helpful for optimizing our cochlear implant candidacy criteria. With that, I'd like to thank all of my co-authors for their contributions on this project, as well as ANS and COSM for giving me the opportunity to present. And of course, you all, the audience, for your attention today. So thank you, and I'll be happy to take any questions later.
Hi, I'm Douglas Bennion. I work with Dr. Guymon and Dr. Hansen at the University of Iowa, and I'm really excited about the chance that I have to present on some of our work using Zwitterionic hydrogels for the coating of cochlear implant biomaterials and cochlear implant arrays and the reduction in friction and force. This is my disclosure slide. We're also grateful for the ANS providing research support for this award, as well as the NIH and collaborative support technically from IOTA Motion. In the last several years, there's been a real flowering of improved surgical technique and array design that is designed to incorporate and utilize residual acoustic hearing following implantation. We also know, however, that implantation itself results in loss of some of that acoustic residual hearing, specifically in the low frequencies. Electrocochleographic studies have demonstrated that there's a loss in decibel hearing level of approximately 10 to 20 plus acutely during the course of implantation, and that over time that averages out to a higher loss of 40 decibels, with later losses probably incorporating other immune factors and fibrotic response of the immune system to the implant itself. The early acute damage is likely related to trauma within the cochlea, with specific events such as basilar membrane elevation or fracture of the osseous spiral lamina, resulting in damage to spiral ganglia neurons and other contributing traumatic events leading to loss of that residual acoustic hearing. So what can be done to prevent this loss during implantation? Incorporating work from the biochemistry lab of Dr. Guymon at the University of Iowa, we have been excited about Zwitterionic hydrogels, and briefly I'll tell you what that is. Monomers are placed in a solution, these Zwitterionic monomers with a positive and negative charge, And when placed in the solution with a photo activating agent and exposed to UV light, substrates which have been pre-treated are actually able to be photografted with covalent bonds, and the monomer molecules are able to be polymerized, forming a stable hydrogel on the surface of the substrate. Zwitterions such as sulfobutane methacrylate, SBMA, they have the advantage of being, once hydrolyzed, polymerized like this and in a hydrogel, have the advantage of holding tightly to water molecules at the surface, which results in a net neutral charge and is energetically unfavorable to be displaced, meaning that there's unique anti-fouling properties. This is also a substance that can be coated in an ultra-thin manner, allowing for manipulation of these types of devices in very small spaces, such as the round window on the surface of cochlear implants. First, we wanted to assess whether coating with a hydrogel like this would result in a reduction in friction. And so we used tribometry as pictured here to assess that. In a cup, we were able to place flat silastic sheets that were either coated or uncoated, and then using a ball tip probe attached to a sensitive measure of force and a subsequent friction analysis, you're able to measure the interface between substances such as a steel ball tip probe, a ceramic ball tip probe, or coating that probe with some subdermis from guinea pigs. We were also able to look at biological surfaces. And what we found was an impressive reduction. On the y-axis here, you can see the normalized coefficient of friction. In gray, you see the uncoated coefficient of friction between steel, ceramic, and dermis. And then when you take that and you coat these SBMA, with SBMA, you coat the silastic, you have more than a 90% reduction in the coefficient of friction on these synthetic surfaces as well as on biological surfaces. The next problem we ran into was how to get such a fine coating on a three-dimensionally complex structure like an electrode array tip. And so we developed a sleeve coating method that involves pre-treating an array tip with a activating agent that allows for the covalent bonding of the coating, and then using an unpre-treated sleeve that's slipped over the top. Solution is instilled between the two, and a UV light is exposed with the photoactivator in place to allow for polymerization and photografting. And then the outer sheath is removed with a thin coat hydrogel on the outside surface of the array in a manner that's geographically selective, as you can see pictured here. When we dip these in fluorescein dye, the water layer takes up that fluorescein and is very easy to see on light microscopy just along the array tip and over the electrodes. When you look at the right of this figure, you have an uncoated array pictured here with scanning electron microscopy as compared to a coated array tip, which you see there's some desiccation artifact that's just artifactual as a result of the drying required for SEM imaging. The array tip coated in other scenarios is smooth. The blue pictured here, the aqua color, is the silicon atoms, which with energy dispersive X-ray spectroscopy emit at a certain frequency, and then we can observe a sulfur energy dispersion with the coated array showing a uniform and complete coverage. We next took these arrays and wanted to assess whether forces within insertion models would actually be reduced in the presence of reduced friction. So we used a force transduction system pictured here. We actually used harvested human cadaveric cochlea from fresh frozen samples. This is a synthetic model just for the picture. And we inserted using a micromotor system to decrease the variability of insertion from user to user and trial to trial. Here's a representative example of a lateral wall electrode that was inserted over time with the force in millinewtons being pictured on the y-axis and the time of insertion on the x-axis. And you can see that over the course of the insertion, the forces increase to the point of maximal insertion. We used arrays lateral wall both from two different companies and measured uncoated array insertion forces and compared those to coated array insertion forces, which you can see pictured here below. And the overall insertional maximum force was significantly decreased, and I'll show you the aggregate data or the summary there. Also, the variability of the force over time was decreased. And finally, by normalizing to the distance of insertion, we were able to calculate a measure of work, and overall work of insertion was decreased. And here are those data summarized. So the maximum insertion force was significantly decreased in the coated condition with 9 electrodes in each group. The insertion force variation was significantly decreased, as well as the work of insertion being significantly decreased. To summarize, we found that this coating provides uniform photografting and photopolymerized hydrogel on the surface of implants, that those hydrogels result in reduced frictional force and insertion forces. We hope this will translate into ultimate reduction in insertion trauma, preservation of low frequency hearing, and future studies are going to be looking at the exciting aspect of this array tip coating method, which might result in decreased fibrotic response with decreased adsorption of protein, bacteria, and cells to the array within the cochlea over time. I'd like to acknowledge my team, my mentors, the graduate students who I've had the pleasure of working with, our collaborators, and the American Neurotology Society.
He won the ANS TRAINEE award, that $1,000. If you could offer him congratulations, please. You're muted.
Is it for me? Yeah. I'd just like to acknowledge the last speaker, Douglas, for receiving the ANS TRAINEE award this year.
All right, good morning. My name is Matthew Shew, and I'm the Neurotology Fellow at Washington University. And I'd like to thank my co-authors as well as the 532 study group and also the ANS for the opportunity to present our work looking at the impact of age on noise sensitivity in CI recipients. Sorry, these are our disclosures. So identifying and treating hearing loss in the elderly is a significant public health priority because of the growing aging population, the fact that we severely undertreat hearing loss, and that there's a growing body of evidence that hearing loss and cognitive decline are directly linked. One of the challenges we face today is the confusion surrounding candidacy criteria. Most private insurers follow the US FDA criteria revised in 2000 for the cochlear nucleus system, which requires less than 50% in the candidate ear and less than 60% in the best aid condition. However, most adults over the age of 65 receive healthcare from CMS or Medicare who have the strictest criteria, requiring less than 40% in the best aid condition. Where it gets confusing is that neither criteria specify the test materials or the use of background noise. And we know that testing a noise is important to help identify patients that will gain significant benefit from a CI that would not otherwise be identified. Two great studies have demonstrated the wide variety of practice patterns between CI centers across the United States. And more importantly, both have highlighted the confusion on testing and noise and how it's applied and who it's applied to. So the objective of the study was to evaluate the impact of noise on different open set speech recognition tests in adult CI recipients above and below the age of 65. This is important because we need to better understand noise on candidacy testing and performance in the elderly, especially as we move forward, creating best practice guidelines for adult CI patients. I think we all agree we ultimately don't want to qualify an implant patient that won't gain significant benefit. And so our hypothesis is that the elderly are more noise sensitive. So to evaluate these questions, we performed a secondary analysis on the 532 clinical trial, which was a prospective trial encompassing 13 centers across the United States to evaluate the performance of the new slim perimedial electrode. We separated patients into two groups based on age and evaluated speech perception performance, both preoperatively and postoperatively in the ipsilateral ear alone, as well as best aided condition. As you can see, these were the inclusion and exclusion criteria. Of note, patients were qualified if they had a C&C score less than 40% in the candidate ear and less than 50% in the contralateral ear. As expected, older adults had longer durations of hearing loss and hearing aid use. We also observed that older adults had a lower preoperative MoCA score compared to their younger counterparts preoperatively. Preoperatively, there was no significant difference in baseline performance between the two age groups across all three speech perception performance measures, and both groups showed significant improvement across all three speech measures 6 months postoperatively. So as we look at individual speech tests, we see that C&C scores, we observed no difference in performance at 6 months in both conditions. However, when we look at the delta of improvement, we observed that older adults had a significantly smaller delta in improvement compared to younger adults. Then, when we look at AZ-Bio plus 10 dB signal to noise ratio, we observed that older adults performed significantly worse in both conditions at 6 months. Then, when we look at the delta improvement, we see that older adults had a significantly smaller delta in the CI only condition compared to their younger counterparts. And then finally, as we decrease the signal to noise ratio at a plus 5 dB, we see that this effect is even more dramatic. We observe that the difference in overall performance is significantly worse and that the delta in improvement is significantly less in older adults across both conditions. When we evaluated MoCA and quality of life measures as confounding variables for performance across all three testing scenarios, we observed no difference in testing candidacy or performance between the older and younger patients. So as you can see, C&C, the two age groups performed overall the same, and delta was relatively the same as well. However, once we start adding noise and decrease the signal to noise ratio, we see that the elderly are disproportionately affected. There are a variety of mechanisms proposed, but it's clearly a central rather than a peripheral issue. However, further work is needed to further elucidate the underlying mechanisms behind this. Limitations of the study include that we only analyze cognition function using MoCA, which is not a full cognitive battery, particularly since we know the effect of noise is a central phenomenon. Furthermore, we did not evaluate and compare AZ-Bio and quiet. And finally, we only evaluated 6-month outcomes, which may not account for the fact that the elderly may require longer time to centrally adapt. So in conclusion, as you can see from the study, the elderly are disproportionately sensitive to noise compared to younger adults. It's interesting how in quiet we observe similar outcomes between the groups, but as we add larger amounts of noise, we can clearly see that the older adults are disproportionately affected. We know testing in noise is important to help identify patients that would qualify and benefit from a CI that wouldn't otherwise be identified. And we also know that testing noise is important for patients with asymmetrical hearing loss. However, we believe that the study supports that caution should be exercised when adding noise in the elderly. But before any definitive conclusions can be drawn over this disproportionate effect, future studies will need to directly assess the effect on candidacy testing using different varying levels of noise and larger battery of speech testing. I'd like to thank my co-authors as well as the ANS for the opportunity to present our work. And here are our references.
Thank you very much, Dr. Shew. And we'd like to extend our congratulations to you as the recipient of the Neurotology Fellow Award.
Thank you.
Good morning, everyone. My name is Elizabeth Perkins, and I'm the second-year neurotology fellow at Vanderbilt. And today I'm going to be speaking about the influence of cochlear implant electrode array type and position on hearing preservation. So I have no disclosures, but these are the disclosures of my team members. So over the last decade, the indications for cochlear implantation have expanded to include those with preserved low frequency hearing. And we know that combined electric and acoustic stimulation affords the potential for improved sound localization, speech perception of noise, and music appreciation. And there are many factors known to influence hearing preservation in cochlear implantation. So that includes your insertion technique, the electrode length, and the electrode array type, with a pre-curved styleted array known for higher rates of translocation from the scala tympani to the scala vestibuli, causing trauma to the cochlea, therefore lower rates of hearing preservation. But more recently, Cochlear has developed a pre-curved, non-styleted electrode array called the 532 or 632, which there have been many reports of successful hearing preservation with this electrode array. So our institution has previously demonstrated that electrode position can influence speech performance, and this may vary between the type of electrode. So for example, for straight electrode arrays, a greater angle of insertion was associated with improved speech performance, but for the pre-curved electrode array, a decreased perimodiolar distance was associated with improved speech performance. So this led us to ask the question of how does electrode array position influence hearing preservation, and does the longevity of hearing preservation vary between electrode array type? So we performed a retrospective chart review of all of our cochlear implant recipients over a 6-year time period who had preserved low frequency hearing postoperatively. We then divided them by the type of electrode array that was used. And then all of our patients immediately postoperatively within the OR get a CT scan. And we use that CT scan to perform analysis of the electrode array position. So we measure things like the mean perimodiolar distance, the base insertion depth, angle of insertion, and the scalar position. And then we used a stepwise multiple regression and ANOVA for our statistical analysis. So overall, we had 121 adult cochlear implant recipients. About half of our cohort was implanted with a straight electrode array, 26% with a pre-curved styleted array, and then the remaining 24% were implanted with a Cochlear 532 or 632. So overall, this graph represents the electrode array position amongst the varying electrode array types. These results are pretty intuitive. So the pre-curved non-styleted electrode array had a significantly smaller mean perimodiolar distance. There is no difference in base insertion depth, but the straight electrode array had a significantly deeper angle of insertion compared to the other two. So these two graphs represent the low frequency pure tone average from activation to the last follow-up for each electrode array type. So the graph on the top of the screen represents the LFPTA over time for each electrode array type. But the graph on the bottom of the screen is comparing the LFPTA at each time point between the electrode array types. What we see is that all the electrode array types have significant increases in their LFPTA after activation, and that's due to the expected threshold shift. But patients that were implanted with a pre-curved styleted electrode array had a significant difference between activation, LFPTA, and their last follow-up. In addition, when compared between electrode array types, the straight electrode array had a lower activation LFPTA, and that's because probably the selection bias of the patients who undergo implantation with a straight array. And then the pre-curved electrode array had a higher 6-month and last follow-up LFPTA. But we know that just looking at the LFPTA doesn't show the whole picture. So these two graphs are set up similarly, but they show the LFPTA shift. And interestingly, you notice that there is no significant difference in activation, 6 or 12-month, and last follow-up LFPTA for each electrode array type, and when separated by and compared to the other electrode array types. And then looking at the results of our stepwise multiple regression, our pre-operative LFPTA and age of implantation were both significant predictors of LFPTA shifted activation. But LFPTA shifted activation, scalar position, and base insertion depths predicted LFPTA shift at 6 months, but only the LFPTA shift at 12 months was found to be a significant predictor of LFPTA shift at last follow-up. So overall, we concluded that the LFPTA shift postoperatively did not differ between electrode array types. Although the pre-curved arrays did have a significantly deteriorated LFPTA at activation and last follow-up, this was not significant when comparing LFPTA shift. In the preoperative LFPTA and age of implantation were both significant factors for the initial and 6-month hearing preservation rates. And this is consistent with what you know can influence hearing preservation in our population. But we did not observe a trend between angle of insertion and perimodiolar distance with short and long-term hearing preservation. Of course, I'd like to thank my team that made all this research possible and the ANS for giving me the opportunity to present my research today. And if anyone has any questions, feel free to email me if outside the question session. Thank you.
Hi, thank you. My name is Ted McCracken. On behalf of my colleagues, I'd like to thank the American Neurotology Society for allowing me to present on our work on the role of preoperative patient expectations and adult cochlear implant outcomes. Our disclosures are displayed here, and we are very appreciative of our funding sources for this work. Patients' expectations with regard to medical interventions have been studied in a variety of fields. This includes pain control or mobility after orthopedic surgery. However, these have rarely been studied in adult cochlear implant recipients. But this is very important for adult cochlear implant users for 3 main reasons. One, the transition from poor acoustic hearing to electrically stimulated hearing is a dramatic change, and it'd be important for patients to kind of know what to expect after implantation. Second, it's a potential modifiable patient factor that may have an impact on patient outcomes. Third, when determining cochlear implant candidacy, the work of Sandy Prentice and others have demonstrated that audiologists consider patient expectations to be one of the most important factors in determining candidacy. So the aim of this study is a hypothesis generating study is to examine the associations between patients' preoperative outcome expectations and their postoperative quality of life, speech recognition abilities, and overall satisfaction with their implant. This is a retrospective review of a prospectively maintained database plus a questionnaire. These are typical traditional implant candidates who were adults with bilateral postlingual hearing loss. Patients were excluded for revision implants or single-sided deafness implantation. Speech recognition outcomes included preoperative aided and 12-month postoperative CNC words and AZ bio sentences and quiet. We did not have adequate data for sentences and noise. The questionnaires included the Cochlear Implant Quality of Life 35 profile instrument and a visual analog scale that's looking at patient satisfaction on a 0 to 100 scale. The expectation questionnaire was completed prior to cochlear implantation, and this included 44 statements that patients completed whether or not they expected to agree or disagree with a particular ability related to cochlear implantation. This has been used for a number of years in our clinic. Higher scores here are associated with higher preoperative cochlear implant expectations. Given the lack of preliminary data, there was no power analysis done for this study. And therefore, we used Cohen's d to measure the effect size and will not discuss any statistical significance of our findings, given the lack of power analysis. Overall, 104 cochlear implant users met our inclusion and exclusion criteria and were invited to participate in the study. Approximately 40% of those invited did enroll. Overall, looking at our CI quality of life outcomes, patients with lower preoperative expectations actually had higher cochlear implant quality of life scores for all domains except the environmental domain. As seen here on the x-axis, the domains are listed. In blue are listed the patients with the lower expectations, and in orange are the patients with the higher expectations. The y-axis represents the CI quality of life score. We found large effect differences between those with low and high expectations for the emotional, entertainment, and social domains, and medium effect sizes for the communication, listening effort domains, and the overall global score. As mentioned previously, no substantial effect for the environmental domain. In contrast, in looking at the speech recognition data, high expectations had a small but really essentially negligible effect on improvement in speech recognition outcomes. As seen here, CNC words and AZ Bio sentences and quiet, the differences between the low expectation group and the high expectation group are within the measurement error of speech recognition testing. Our satisfaction data was maybe a positive spin here, a little bit limited by the clustering of our satisfaction scores in the higher range of our scale with a mean score of 81.1. However, we did a secondary analysis by breaking patients down into the lowest quartile and the highest quartile of satisfaction scores to identify any differences. We found no detectable associations between patients' pre-CI expectations and their satisfaction, but we did find that patients with higher satisfaction had higher cochlear implant quality of life domain and global scores, with the largest effect seen on the cochlear implant quality of life communication domain. In contrast, we found minimal to absent associations with satisfaction and speech recognition abilities. So we found preliminary results that suggest an association between preoperative outcome expectations and self-reported functional abilities as measured through our quality of life instrument. However, the question remains, do lower expectations really result in better real-world outcomes? There are some established theoretical models that may describe this, as seen here for the expectation discrepancy model, where patients' expectations are compared to their ultimate outcome, and the degree that these match or do not match result in the patient's final satisfaction. However, when we talk about patient satisfaction and functional outcomes, there's not a one-to-one relationship here. But our data do suggest that there's potentially a stronger association between patient-reported outcome measures, and this is supported by others, and patient satisfaction, rather than with patients' speech recognition outcomes or improvement in speech recognition. However, cochlear implant outcomes expectations remain a bit of a black box. Despite being identified as a critical factor, we really have no way to determine whether patients' expectations are realistic when talking about overall patients' cochlear implant outcomes. Therefore, we have actually developed and are currently validating the cochlear implant quality of life expectation instrument. This is based on the face and content validity of our other cochlear implant quality of life instruments. And this will actually allow patients to provide values and actually write their score their expectations, and we'll be able to compare those results to the normative data from our other quality of life instruments to determine whether the patient's expectations are realistic or not. Moreover, this will get rid of kind of the subjective way we currently discuss expectations with patients and determine whether or not their expectations are realistic. So in conclusion, preliminary evidence show that patients with lower expectations prior to cochlear implantation were at higher postoperative quality of life. This appears to be independent of speech recognition abilities. Overall, cochlear implant related satisfaction is very high, but much strongly associated with postoperative quality of life than with speech recognition abilities. However, there are some limitations to this study, and confirmation is needed through prospective research design, more sensitive expectation and satisfaction outcome measures, and in larger sample sizes. I'd like to acknowledge our research team and our cochlear implant team, as well as our funding sources for their support of this work. Thank you.
Hi, everybody. I'm Ashley Nasir. I'm a first-year neurotology fellow at the Mayo Clinic. Thank you to the ANS for allowing me the opportunity to speak today. Today, I'll be discussing time to peak speech perception scores after CI and single-sided deafness. I have no disclosures related to this study. So as has been reported previously in the literature, there are several reasons to support the positive benefits of cochlear implantation in the single-sided deafness community. Some of the benefits of CI in the SSD community are listed here and include improvement in sound localization, improved speech perception and noise, reduction or elimination of tinnitus, and improved quality of life related to hearing. Similar to the traditional CI cohort, however, the SSD cochlear implant patients have variable outcomes on an individual basis. One of the interesting aspects of studying the outcomes in the SSD population is that some prior reports have alluded to differences in speech perception outcomes in this population when compared to the traditional CI patient population. Some studies have reported a lower peak speech perception score overall within the first year or two after implantation. And another aspect that has been alluded to, but not specifically studied previously, is variable timing that it takes to have a patient reach their peak speech perception score postoperatively. To our knowledge, however, no prior study has directly compared this time to peak speech perception score between the SSD and traditional CI cohorts. So that was one of the main goals in this study. So specifically, we wanted to compare peak scores between SSD and traditional CI patients within the first year after cochlear implantation. And then next, we wanted to compare speech perception performance growth, or what we will call time to peak speech perception score, between the two cohorts as well. We used a matched cohort study design, which was a retrospective study that included patients with up to 1 year of follow-up after their surgical implantation. We included 33 SSD patients, and we matched on a 1:2 ratio to 66 traditional CI patients. We matched on duration of deafness and preoperative CNC score. We did attempt to match on age. However, given that the SSD cohort is fundamentally younger than the traditional CI patient cohort, we were unable to do so and made some age adjustments after our analysis. The last thing we had to define was, what does it mean that a patient has reached a peak speech perception score? So in order to determine what a peak speech perception score was within the SSD and the traditional CI cohorts, we looked back to the previously published literature and included several studies to determine what a weighted mean CNC and AZ-Bio score would be for each of the groups. We defined a patient reaching peak score in this study as reaching within 80% of these weighted means that were determined from the literature. So we performed our cohort comparison. We did find that overall, the SSD cohort had lower peak CNC and peak AZ-Bio scores in quiet when compared to traditional CI patients with bilateral sensorineural hearing loss. And that was statistically significant for both CNC and AZ-Bio scores. Next, we looked at the time to peak CNC score, as well as the time to peak AZ-Bio scores. In other words, how long did it take for patients to get to their peak score within that first year of follow-up? For CNC scores, the SSD cohort did reach their peak at a median of about 3 months compared to 6 months for the traditional CI group. However, that difference was not statistically significant. Similarly, the time to peak for both groups was a median of 3 months, and there was no difference there. We also looked at how likely was it that a patient within these different cohorts was going to reach peak. So what percentage of patients actually reach their peak CNC score within the SSD versus the traditional CI cohort? Similar to the time to peak, the SSD cohort performed slightly better and were more likely to reach their peak within that first year of postoperative follow-up. But for both CNC and AZ-Bio scores, these differences were not statistically significant. So when we look at all of these results, what conclusions can we draw? First of all, our study did reemphasize that it appears that the SSD cohort does have lower CNC and AZ-Bio and quiet scores within the first year of follow-up when we compare them to traditional CI candidates with bilateral sensorineural hearing loss. What was interesting was that we did not find that the SSD cohort performed, or I should rephrase that, reached their peaks more slowly than the traditional cohort. We didn't find a difference between the cohorts. So both the SSD and traditional patients were just as likely to reach peak and just as likely to reach peak within a similar amount of time. There's an interesting factor related to how we understand SSD-CI outcomes, and I think that's partially related to the role of the contralateral ear. You can view this in a positive or a negative light. Positively, that normal hearing ear on the contralateral side can serve as a coach as the newly implanted ear is learning how to listen and interpret new sounds in speech. But more negatively, some may perceive this as the individual relying on a normal hearing ear rather than using that cochlear implant side. And so a better understanding of how that contralateral ear impacts SSD outcomes is something that we'll work on in the future. I have our references listed here, and I'd like to thank my colleagues and be happy to answer any questions at the end of the session. Thank you.
Thanks everyone for letting me speak today. My name's Jim Dornhofer, and today I'm going to be discussing factors that influence second-sided cochlear implant speech recognition in bilateral recipients. Here are our conflicts of interest and our sources of funding. Cochlear implants have become the standard of care for severe to profound bilateral sensorineural hearing loss, with many patients undergoing successful therapy with just unilateral implantation. However, bilateral implants may offer certain benefits with respect to speech recognition and noise, localization, and quality of life. However, the decision to progress from unilateral to bilateral implantation can be challenging, particularly for patients who have some degree of residual hearing, as they have to balance their current real benefit they get with a hearing aid against the potential benefit of a second implant. Unfortunately, there's very limited data to help guide this progression and offer appropriate expectations. As such, this study aimed to identify factors that might influence second-sided cochlear implant speech recognition outcome in bilateral recipients. To do this, we performed a retrospective review of a database maintained at our institution. We identified patients who had undergone bilateral implantation, and then we collected demographic data, pre-implantation aided audiological data in the second ear, and post-activation data in each implant, taken at least 1 year post-activation and at the same interval post-activation for each ear. We then utilized correlation and multivariable regression to determine any significant associations. 102 patients were identified in this study, and the average interval between first and second implant was about 2 years. Overall, patients did well. As seen here, patients saw a significant increase in speech recognition in each implant, and there was no significant difference between either side. Unfortunately, there was insufficient speech recognition data and noise for analysis in this study. When we performed our correlation, we noted that no demographic factor had any significant influence on second-sided outcomes. We also found that pre-implantation aided data in the second ear was not significantly associated with post-implantation speech recognition in that same ear. However, we did note that a patient's performance with their first cochlear implant was very strongly associated with performance in their second. This is illustrated with this graph on the right, in which we have charted a patient's AZ-BIO scores in their second implant in the y-axis against their first implant in the x. And from this, we see a very strong correlation. However, these speech tests do have a certain margin of error associated with them. To control for this, we utilized previously published 95% confidence intervals for each speech test. This is represented in red brackets on this chart. Patients lying above these brackets, we can say did better with their second implant, and patients below this bracket, we can say did worse. In patients lying within the 95% confidence interval, the majority of patients in the study had equivalent scores ear to ear. From this, we see that about 2/3 to 3/4 of patients performed equivalent or better with their second implant as compared to their first. We then utilized a multivariable regression to control for any confounding demographic factors. And once more, we see that a patient's speech recognition performance with their first implant was the strongest predictor of speech recognition scores in their second. Given the R-squared, or coefficient of determination, we see that 24 to 40% of variance in second-sighted outcomes may actually be directly related to outcomes with their first implant. From this, we've established a very strong relationship between first and second implant outcomes for bilateral recipients. This helps to provide some expectations for patients considering progressing to bilateral implantation. Namely, they can anticipate that their scores with their second implant will be very likely similar to their first, and that about 2/3 to 3/4 of patients should anticipate doing equivalent or better with their second implant. This strong association between first and second implant also raises interesting points about factors that influence implant outcomes in general. Given the coefficient of determination seen in our multivariable regression, we hypothesize that given any given implant, maybe up to 40% of variance in speech outcomes may be related to factors that are actually shared between ears, such as CNS plasticity and various environmental factors, with the remaining variance related to ear-independent factors, such as cochlear health or specifics of the surgery or electrode array. This may be of use to future studies examining implant outcomes. This study is limited in its single university-based design, lack of speech and noise data, and failure to address non-audiological outcomes such as quality of life. However, we feel we can conclude that for patients considering bilateral implantation, their performance with their first implant may help to predict performance with a second, thus providing some preliminary evidence-based recommendations for patients considering this transition. However, such counseling must remain guarded, as there is still a good amount of variability we cannot directly assess within the study. I'd like to thank my team very much for the help with this project, and thank you all very much for your time today.
Hey, I'm Nate Cass. I'm the fellow at the Neurotology group at Vanderbilt, and these are my collaborators, Doug Totten, Liz Perkins, John Ross, and Matt O'Malley. I'm excited to talk today about characterizing cochlear implant magnet-related MRI artifact. No disclosures. Although cochlear implants used to be an absolute contraindication to MRI, recent changes to the design, including removable magnets, head wraps, and most recently rotatable diametric magnets, have enabled greater access for CI patients. However, magnet-related artifact remains a challenge. This is important because although 1/4 of MRI scans in the general population are of the head and brain, this number rises to 50% in cochlear implant patients. So how can we make these scans as useful as possible for our CI patients? We sought to reproducibly characterize magnet-related artifact for different MRI sequences to enable construction of useful sequence protocols. And secondly, what percentage of CI patients' MRI scans could be rendered more useful by preoperative planning of the receiver stimulator location? To do this, we sought to determine the proportion of post-implant MRIs that were performed for indications that were known of prior to implantation versus new indications. So during MRI, the implant magnet causes proton spin dephasing and loss of coherence in adjacent tissue, resulting in signal void and sometimes distortion of the image. This is an axial MRI scan. And when you scroll up and down on one of these axial MRI scans on an implant patient with a retained magnet, you find that close to the area of the magnet, the level of the magnet, that artifact becomes circular. And at the actual level of the magnet, that artifact reaches its greatest size. So we performed ellipsoid modeling and calculated the artifact radius at the axial level of greatest signal loss, like so. We did this across 5 representative sequences, T1 and T2 weighted fast spin echo and gradient echo sequences, as well as diffusion weighted imaging. Of note, the T2 weighted gradient echo sequences include the Fiesta and KISS sequences. We calculated the average artifact radius and compared via logistic regression across these 5 representative sequences when available. We had 20 patients and 52 MRI scans, and we found in those that the T2 weighted gradient echo sequences and the DWI had significantly greater mean artifact radius at between 7 and 8 centimeters compared to the other 3 scans that were approximately 5 centimeters in radius. This is unfortunate because, as we know, the T2 weighted gradient echo sequences such as Fiesta and KISS are extremely useful for delineating the fine cranial nerve structures of the skull base. And DWI is heavily utilized by neuroradiologists in the acute setting, especially when looking for stroke or subdural hemorrhages. So we looked at the indications for why these scans were obtained and whether they were for issues that were known of prior to the implantation, such as skull base tumors, versus those that were obtained for workup of a new issue. We found that nearly 3/4 of them were for known indications. But there was no statistically significant difference in the ability to adequately visualize the clinical structure of interest between these two groups. The limitations of this study include the fact that measuring an unintended artifact can be imprecise. For instance, on coronal and sagittal scans, the artifacts are not circular, they're more irregular, and the shape of the irregular shape differs more between type of sequence, gradient echo and fast spin echo sequencing. So, but I think that the axial way of measuring them is fairly accurate because it's reproducible. The determining the adequacy of the scan is likewise difficult. It amounts to a judgment call by the neuroradiologist. For instance, in some occasions, we could tell whether a known tumor was growing, but we couldn't accurately measure it due to distortion, so the software calipers weren't very useful. Most of our patients get MRI scans at outside imaging centers and bring them to us for review. So the breadth and the quality of the scans is pretty heterogeneous. Finally, it's a retrospective low volume single center study. A multi-center study would probably be more useful, but I think you'd still run into the same problems with scan heterogeneity. So in conclusion, magnet-related artifact may be reproducibly reported as radius of an ellipsoid mapped to the visible edge of the signal void at the axial image level of maximal signal loss. The cochlear implant MRI sequence should be built around fast spin echo and T1 gradient echo sequences. From what I can tell and from what I've read, 3D T2 fast spin echo imaging might be a good alternative, good possibility for instead of using Fiesta or KISS sequences, and might be less susceptible to magnet-related artifact. We don't yet use this at our center though. And third, the majority of implantees who undergo head and brain MRI are for indications that are known of prior to implantation, and these may benefit from preoperative receiver stimulator location planning. This is a picture from an article by Tott et al. In 2015 showing a typical implant position placement. It's a 120-degree Nasion EAC angle with the internal magnet 7 centimeters from the EAC. And when they strapped CIs to the heads of volunteers and put them in MRI scanners, they found that using a 90-degree or 160-degree Nasion EAC angle and placing the internal magnet 9 centimeters from the EAC were more helpful in visualizing the ipsilateral temporal bone. So this could be an option for patients that have pathology that's known to need MRI scans after implantation. These are my references. Thanks very much to the ANS for the opportunity. And I'm happy to take any questions now or through my email.
Well, welcome back. Congratulations. And thanks to all our speakers. We'll now address, we have many questions from attendees and several from Dr. Roland and myself. We'll start with Dr. Tai from Dr. Sharon. Very interesting work. Did anyone who qualified in noise but not in quiet perform worse post-operatively?
Thank you, Dr. Sharon, for the excellent question. So I just like to point out, first of all, we excluded patients with any device failure. And then if you remember, we had the threshold of 15-point increase for improvement. If we applied that same threshold for worsening, actually, we only had one patient who worsened beyond 15 points in terms of patients who qualified in noise but not quiet. And from looking through the medical record, didn't seem to be anything that jumped out at me. The only thing was they had a very low daily CI usage, and it's unclear whether that's causing the patient to do worse, or if the patient's doing worse so they're not using the CI more. So I think just for clinical practice, I don't think there's any need to counsel patients about getting worse if they only qualify in noise, but that they are less likely to benefit, at least from our preliminary data.
Well, Lundberg's, may I ask another question about that? You know, if you give people enough noise, you can qualify anybody. And we've had other series which have showed patients can do worse post-operatively if they're only noise qualifiers. So did you look at CNC results? Is that perhaps a better overall evaluation? So since there's so much variability of the AZ bio scores.
Right, so we actually did also look at CNC, and CNC does have a little bit of variability as well, about plus or minus 10. And we saw broadly similar results to AZ bio quiet, where the noise group is less likely to improve compared to the quiet group. But if you look at the general mean, they do improve. And it's a similar result where a few of the patients did do worse, but the majority just performed about the same as before, similar to the AZ bio quiets.
What does adding noise actually measure? Are we measuring central functions, or are we still testing peripheral function?
Right, so I think it's just more representative of the daily life. You know, it's very rare for someone to be in just a completely quiet situation. So, yeah.
Okay, thank you so much. Question from Dr. Sun to Dr. Bennion. Great presentation. What are the electrical properties of the Zwitterionic coating? And what would be a potential strategy to avoid coating over the electrode contacts?
Thanks, Dr. Sun. That is a good question. And actually, the platinum electrodes are likely much of the immunogenic property of the electrode array tip that results in the fibrotic response may be driven by the platinum, in addition to the silastic housing. And so while you may consider that having a coating over the electrode would be a bad thing for the transmission of the electrical signaling, it may actually be a benefit to have it coated to prevent the immunogenic response. In addition, specifically with the Zwitterion hydrogel, you have the advantage of positive and negative charges within the monomers, which translates into the polymeric version. And there's evidence to suggest that electrical transmission through that such a substance should not be hindered and maybe even more specific. So coating over the electrode placodes themselves may be advantageous with the electrical properties of a Zwitterion coating versus some other coating that would increase the impedance. So we're hopeful that and plan to actually look at whether impedances are impaired or improved in the presence of hydrogel coating. And we think that very likely there's a chance there would be decreased immunogenicity and decreased fibrosis within the cochlea with the coating of both the silastic housing as well as the platinum placodes themselves.
Thank you, Dr. Bennion. Maybe I missed that part of the talk. Did you mention its biocompatibility? Are macrophages going to be happier with this coating versus just plain silastic in the cochlea?
It's a really good question, and in vitro we see that the coating is it has a great anti-fouling property to it, that there is very little adhesion of fibroblasts, macrophages, proteins, bacteria, and we are very hopeful that in vivo experiments where we're implanting cochlea will show that in vitro reaction, or lack of reaction, I should say, is going to be representative of the biological response as well. We have done it subdermally with implanted coated silastic in mice and have shown a marked reduction in fibrosis and macrophage response.
Okay, thank you very much. For Dr. Nassiri, we have several questions regarding your SSD paper. Great presentation from Dr. Gantz. How was the SSD cohort tested? Direct connect or earplug in contralateral ear? Were the traditional CI patients tested using the same method? Or for example, did they receive sound through the CI microphone?
Thanks for the question. So for the SSD patients, they received sound field with plugging. The CI patients from the traditional cohort that were collected and included in this study were tested in a similar manner so that they could be more directly compared. And I think I saw another question. Should I just answer that one too already?
Dr. Din, yeah, at my institution, we have our SSD patients plug their better ear as much as possible in the first 6 months to maximize CI outcomes. So is this considered in these patients? We do a very similar thing. We offer direct streaming to the CI and have them do reading exercises. And we try to maximize their CI use and encourage increased data logging and CI use while they're training that ear. But as we mentioned, there is an incomplete understanding of what role the contralateral normal hearing ear plays. And so in different lights, it's possible that that other ear may actually help with coaching. So as of right now, since that answer is not completely figured out, we're kind of recommending both listening just with the CI as well as with both ears. Thank you. And Dr. Hoa wants to know about your longer results. Have you followed up past that 3-month interval? How are the patients doing?
So this study measured up to 1 year. We agree that is absolutely the next step. We would love to have about 2 or 3 year outcomes. One of the main issues that we have is, well, there's a couple, but similar to other institutions, the SSD CI cohort is not huge. And so our numbers are limited, just fundamentally from that standpoint. And then a lot of our patients do really well. And so we don't necessarily have them come back frequently beyond a year, or they come from far away and they receive local care. And so just having long-term follow-up in this specific patient population is challenging. That being said, we are looking to extend this study and look at 2 or 3 year outcomes long-term. And I think that will help us answer some more questions.
Great. And from Dr. Buchman, did you compare the audibility in the implanted SSD ear to the traditional candidates?
We did not perform that as a part of this study, but that's a great point that we can maybe do in the future.
Okay, wonderful. Thank you. Dr. McCracken, when were the patients evaluated with your questionnaire regarding their expectations? Was that before the audiology counseling regarding their expectations, or was it after? Immediately pre-op? Can you give us an idea?
Yeah, that's a great question. It was prior to the evaluation, and it's something we're actually currently looking at now, is the degree to which how modifiable of a factor is expectations, and how much does it actually change pre to post evaluation. So it's a very good question.
And should we be counseling them as low as we possibly can without them canceling their surgery?
Yeah, I think to be determined. I mean, really, this is very preliminary evidence, and kind of it's fodder for future studies to look at that and see how we should be potentially modifying it. So.
Does their level of education or cognitive function have anything to do with their expectation evaluation?
Yeah, we were a little bit limited. It's a kind of retrospective analysis, so we were limited in what we were able to look at. We were able to look at some things like prior hearing aid use, for example. So patients who had prior hearing aid use did tend to have lower expectations regarding their cochlear implant outcome. However, this subset who had actually better aided speech recognition ability had higher expectations. So there's really a lot to tease out, and I think a lot, several things Dr. Ma you referred to are very interesting to look at for the future.
Okay, thank you so much. Over to Dr. Perkins. Oh, we are out of time. Okay. Well, I want to thank all of our wonderful speakers today, and again to congratulate our recipients of their awards, and we will close the session.